Bismillahirrahmanirrahim. Assalamu alaikum everyone and welcome back to OBG with Sadia Idris. We have finally completed our detailed discussion on intrapartum care, and now it is time to see how well we can actually apply those recommendations in an exam scenario. Today, we are going to solve 40 high-yield exam-style single best answer questions based predominantly on the NICE Intrapartum Care guideline. And I want you to approach these questions exactly as you would approach them in the exam. Don't rush to the option that simply sounds familiar. Read the scenario carefully, identify the stage of labor, look at the maternal fetal condition, pick out the important numbers and timing, and then ask yourself, what is the single best next step for this woman at this particular moment? Because throughout this session, you will notice something very important, that exam is not only testing whether you know the guideline. It is testing whether you know when to apply it and when the clinical situation overrides the routine pathway. We'll also highlight the little traps, 4 hours versus 2 hours, 30 minutes versus 60 minutes, nulliparous versus multiparous, and offer versus consider. These are exactly the details that can turn an almost correct answer into the correct SBA answer. Keep your nice concepts in mind. Try to answer this question before I reveal the answer. Let's begin with SBA number 1. So let's start with a very basic looking question, but this is a classic nice trap here. We have a 27-year-old nulliparous woman at 40 plus 1 weeks. She has painful regular contractions every 3 minutes. There is progressive effacement, but the cervix is 3 centimeters dilated. So is she in established labor? Option A, established first stage of labor. B, latent first stage of labor. C, passive second stage of labor. D, prodromal labor because the cervix is less than 5 centimeters. And E, established labor because contractions are regular. The correct answer is B, latent first state of labor. Now why? Because according to NICE, the latent first state includes contractions associated with cervical chain, the cervical dilatation up to 4 centimeters. Established first state is when we have regular contractions with progressive cervical dilatation from 4 centimeters. And this is exactly where the examiner can trap you. You see, painful contraction every 3 minutes and immediately think established labor? No. Contraction frequency alone does not define established labor. For the exam, remember one number, that is 4 centimeters. So 3 centimeters with cervical chain, still latent phase. Okay. Question number 2. A healthy multiparous woman is in established labor at 5 centimeter dilatation. Her pregnancy has been uncomplicated and maternal and fetal assessments are not. Which one of the following is the most appropriate routine maternal observation schedule? A, pulse every 30 minutes, BP and temperature every 2 hourly, pulse, hourly, temperature, BP and respiratory rate 4 hourly, pulse and BP hourly, temperature 4 hourly, pulse 2 hourly, BP and temperature 4 hourly, and all maternal observations every 4 hourly. The correct answer is pulse hourly and temperature, blood pressure, and respiratory rate every 4 hours. Let's build the complete observation pattern because this is very testable. Contractions every 30 minutes, pulse hourly, temperature, BP, respiratory rate every 4 hours, and upper vaginal examination every 4 hours. The easy thing to forget here is the respiratory rate. Students often remember BP and temperature but leave out respiration. So remember it as a pattern. 30 minutes contraction, 1 hour pulse, 4 hours temperature, BP, respiratory rate, and vaginal examination. Now let's see what happens when the cervical progress becomes slow. Okay. Now, a nulliparous woman is in spontaneous established labor. She's at 5 centimeter dilatation. 4 hours later, she is 6 cm dilated, and maternal observation and fetal assessment are reassuring. Membranes are intact. What is the most appropriate next step? A, diagnose immediately and commence oxytocin. B, perform amniotomy immediately and commence oxytocin. C, perform emergency cesarean section. D, suspect delay, provide supportive care and advise repeat vaginal examination in 2 hours. And E, continue routine 4-hourly vaginal examination because 1 cm progress is adequate. So she has progressed by just 1 centimeter in 4 hours. Maternal and fetal assessments are normal. So what do we do? The correct answer is suspect delay, provide supportive care, and repeat the vaginal examination in 2 hours. Notice the wording suspect delay, not immediately diagnosed delay. For a woman in her first labor, cervical dilatation of less than 2 centimeter in 4 hours is one feature that should make you suspect delay. But NICE wants you to look at the whole clinical picture. Cervical dilatation, the contractions, the descent and rotation of the presenting part, rather than treating one number in isolation. Provide support, hydration, and effective pain relief, and reassess vaginally 2 hours later. And here comes your exam number. Less than 2 centimeter in 4 hours. Suspect delay. Then, if progress during those next 2 hours is less than 1 centimeter, then diagnosed delay. Keep this sequence in your mind because exam continues the same patient. Question number 4. Now, the woman in SBA 3 is reassessed 2 hours later. Her cervix has progressed from 6 centimeter to 6.5 centimeter. The membranes remain intact. Fetal reassessment remains reassuring. What is the most appropriate management? Option A, continue observation for another 4 hours. Option B, offer immediate cesarean section. Option C, consider amniotomy after discussion with the woman. Option D, start oxytocin after without amniotomy. And option E, transfer solely because amniotomy is required. See, now we reassess her 2 hours later. She was 6 centimeter and now she is 6.5 centimeter. That means only half a centimeter progress in 2 hours. So now we have crossed the second threshold. Less than 1 centimeter in 2 hours, the delay is now diagnosed. Her membranes are still intact and fetal assessment is reassuring. So the best answer is consider amniotomy. Rupture membranes after discussion with the woman and counseling matters. Explain that amniotomy may shorten the labor by approximately 1 hour, but contractions will become stronger and more painful. Now look at option E because it is a beautiful exam trap. Transfer solely because amniotomy is required? No. NICE specifically says to not advise transfer to obstetric-led care for amniotomy alone. So remember, confirmed delay plus intact membrane, consider artificial rupture of membrane after discussion with the woman. So what happens after artificial rupture of membrane? That takes us directly to question number 5. A nulliparous woman with confirmed delay in the first stage undergoes amniotomy. Maternal and fetal assessments remain reassuring. When should vaginal examination normally be repeated to assess progress? The answer is C, 2 hours. I think this should be now learned by heart. After amniotomy for delay or for a vaginal examination 2 hours later. And if there is no progress 2 hours after amniotomy, the delay is diagnosed and transferred to obstetric-led care should be arranged. So let's put the entire sequence together. Suspect delay, vaginal examination after 2 hours. Less than 1 centimeter progress. Now diagnosed delay. Membranes are intact. Consider artificial rupture membrane. After artificial rupture membrane, again vaginal examination after 2 hours. No progress. Now transfer to obstetric-led care. Good. Now suppose she still is not progressing and we start discussing oxytocin. Now, this has a woman has confirmed delay despite amniotomy, following obstetric assessment, oxytocin augmentation is discussed. Which one statement regarding oxytocin is most accurate? A, it reduces the likelihood of cesarean birth. B, it improves neonatal outcome. C, it brings forward the time of birth but does not influence the mode of birth. On neonatal outcome. D, continuous CTG is only required after the maximum dose is reached. E, epidural must be established before oxytocin started. Yes, please. This statement is correct. C, oxytocin brings forward the time of birth but does not influence the mode of birth and neonatal outcome. Read that carefully. Oxytocin may make the baby arrive sooner That does not mean it makes vaginal birth more likely. It does not improve neonatal outcomes simply because labor has been accelerated. This distinction is exactly the kind of wording the examiner likes. Also remember that oxytocin increases the frequency and strength of uterine contraction, so continuous CTG monitoring is required. And an epidural does not have to be established before oxytocin is started. Analgesia, including epidural, if desired, should be discussed and offered appropriately. So your example is that earlier but does not mean increased vaginal birth rate. Am I clear so far? Now that we have decided to use oxytocin, the next question is how quickly do we increase it? A woman is receiving intravenous oxytocin for confirmed delay in first aid. She currently has 2 contractions in 10 minutes and the CTG is normal. What is the most appropriate approach to dose escalation? I think it should be learned by heart. She has only 2 contractions in 10 minutes and the CTG is normal. So we need to titrate the oxytocin. Option A is increase every 10 minutes and 5 contraction 10 minutes. No. Increase every 15 minutes until 4 to 5 contraction 10 minutes. No. Increase no more frequently than every 30 minutes, aiming for 3 to 4 contraction in 10 minutes. This gives you a lovely exam memory combination: 30, 3 to 4. 30 minutes between increments, 3 to 4 contraction in 10 minutes. Don't aim for 5 contractions just because you want faster progress. More contractions are not necessarily better contractions. Excessive uterine activity can compromise the fetal oxygenation. And that sets up the question number 8 perfectly. Question number 8. Now our woman on oxytocin has 5 contractions in 10 minutes. But notice something interesting. The fetal heart rate is currently reassuring. Should we just continue because the CTG looks fine? A, continue oxytocin because the CTG is reassuring. B, increase oxytocin to improve cervical progress. C, reduce or stop oxytocin until contractions are 4 or fewer in 10 minutes. D, perform immediate cesarean section. And E, administer an epidural and continue the same oxytocin dose. The correct answer is reduce or stop oxytocin until the contractions are 4 or fewer in 10 minutes. This is an important safety point. If contractions become more frequent than 4 in 10 minutes, reduce or stop the oxytocin. And now at another layer. If the CTG becomes pathological, discontinue oxytocin immediately and obtain urgent obstetric or senior midwifery review. So don't wait for fetal compromise before responding to excessive uterine activity. 5 contraction in 10 minutes is already telling you to act. Now let's change the topic slightly and move to epidural counseling. A nulliparous woman requests an epidural during established labor. She asked whether it will increase the likelihood of requiring an emergency cesarean section. Which is the most appropriate response? A, epidural increases both instrumental birth and unplanned cesarean birth. B, epidural prolongs both first and second stage and increases the cesarean section. C, epidural does not increase. So the correct answer is that epidural analgesia is not associated with an increased chance of unplanned cesarean section, but is associated with prolonged second stage of labor, increased chance of venous or instrumental birth. If a primary gravid asks you, if I have an epidural, am I more likely to need an emergency cesarean? Yes. So 4 facts. First stage is not prolonged. Unplanned C-section is not increased, but second stage is prolonged, and increased vaginal birth is increased. Epidural analgesia is not associated with an increased chance of unplanned cesarean section. Now, question number 10. Now, a nulliparous woman has an epidural and she is fully dilated, but the fetal head is not visible. She has no urge to push, and both maternal and fetal assessments are reassuring. Should we immediately start directed pushing? No, not at all. The correct answer is D, delay pushing for up to 2 hours. In a nulliparous woman with an epidural, when there is no urge to push and the head is not visible, directed pushing may be delayed for up to 2 hours after full dilatation. For a multiparous woman with an epidural, the interval is 1 hour. So another beautiful exam pair, if nulliparous 2 hours and multiparous 1 hour. After that passive period, actively encourage pushing unless birth has already occurred or the clinical situation requires another approach. And don't start oxytocin routinely in the second stage simply because an epidural is present. No. Okay. Now question number 11. And from here, we are entering the second stage timing questions. The nulliparous woman without an epidural has reached full cervical dilatation. She has an urge to push and the fetal heart is reassuring. After 1 hour of active pushing, the birth is not imminent. What is the most appropriate next step? Do we immediately reach for forceps? No. Do we call this failure of second stage? No. Do we arrange a cesarean section? No. The correct answer is D. Perform a full assessment of progress, including the maternal and fetal well-being. That is a beautiful, nice principle. 1 hour of active pushing in a nulliparous woman does not automatically mean operative birth. At this point, reassess the situation. Ask yourself, is the head descending? What is the fetal position? Are the contractions adequate? How is the mother coping? And most importantly, how is the baby? If progress is satisfactory and both mother and baby remain well, she can continue pushing and we reassess again after further hour. So remember, in nulliparous and 1 hour active pushing plus birth not imminent, reassess, not intervene automatically. That is your exam trap. Question number 12. Now, this is deliberately connected to the previous question. Our similar nulliparous woman was reassessed after 1 hour and now initially progressed appears satisfactory, so she continued pushing, but now she has completed 2 hours of active pushing and the birth is still not imminent. Now, does her management change? Yes. The correct answer is B. Obtain the senior review and make a decision about the mode of birth. Notice the wording very carefully. NICE is not saying that in exactly 2 hours, every nulliparous woman must have forceps or a cesarean. That would be an oversimplification. What NICE is telling you that once a nulliparous woman has been actively pushing for 2 hours and birth is not imminent, this requires senior review and a decision regarding the mode of birth. That decision depends on the complete clinical situation, the fetal position, the station, the descent, the caput, the molding, the maternal condition, the fetal well-being, and whether an assisted vaginal birth is safely achievable. So your memory sequence is the nulliparous woman at 1 hour, reassess, and 2 hours, obtain the senior review and decide the mode of birth. Please remember these two numbers. They are very testable. Now the examiner only changes one word, and that one word completely changes the timing. Now she's multiparous. She has been actively pushing for 1 hour and birth is not imminent. What should you do? Yes, please. The correct answer is C. Senior review and decision about the mode of birth. So compare this directly with this patient, previous patient, and now this patient. For the nulliparous woman, senior review was required when birth was not imminent after 2 hours of active pushing. For the multiparous woman, it is after 1 hour. This is exactly the kind of numerical distinction that appears in an exam. So keep this tiny table in your mind. Active pushing does not automatic. Active pushing and birth non-imminent in nulliparous in 2 hours senior review and in multiparous 1 hour senior review. And again, senior review does not mean automatic forceps or cesarean. It means reassess the whole situation and make an appropriate decision regarding the mode of birth. Good. Now, this question shifts us from the duration to the maternal position. A woman with an epidural asks, should I lie flat on my back while pushing? And this is where old traditional labor room practices can get you into trouble in an evidence-based exam. supine position or improve fetal oxygenation, supine position, shorten the second stage. She should be encouraged to adopt any comfortable position, but lying flat should be discouraged. It may reduce blood pressure, placental blood flow. She should be supported to adapt a position that she finds comfortable, but lying flat on her back should be avoided because it may reduce maternal blood pressure and placental blood flow. Why? Think the physiology. The gravid uterus in the supine position can compress the great vessels, particularly the inferior vena cava, reducing the venous return and potentially affecting the uteroplacental perfusion. So epidural does not mean put every woman in lithotomy. And it certainly does not mean upright or alternative positions are contraindicated. Obviously, mobility and safety depend on the degree of motor block and the woman's clinical condition, but the principle is support maternal choice and avoid routine flat supine positioning. That is much more aligned with modern intrapartum care. Okay, now we have another very practical questions. She's a healthy woman without an epidural, enters active second stage, maternal and fetal assessments are reassuring. So now, which one approach to pushing is the most appropriate? A, routine prolonged closed glottis pushing. B, encourage her to follow her own urge to push. C, ask her to hold her breath for 10 seconds, please. What do we do? Do we start shouting deep breath, hold it, push for 10 seconds again, not routine? The correct answer is B. Encourage her to follow her own urge to push. In an uncomplicated labor, without an epidural, women should generally be supported to follow their natural urge to push. Routine, prolonged, directed, closed, glottis pushing is not necessary. And notice a broader theme running through the nice slide line. When the labor is physiological and the mother and baby are well, do not interfere simply because you can. Intervention should have a reason. So if you see a question with normal labor, no epidural, reassuring fetal assessment, think support the physiology rather than imposing unnecessary intervention. Okay. Now, this is a lovely little guideline wording question here. A nulliparous woman is approaching birth and wants to reduce her risk of severe perineal trauma. Which intervention can be offered? A, routine episiotomy. B, fundal pressure. C, warm compresses. D, routine lignocaine infiltration before crowning. E, prophylactic forceps. C, correct answer is C, a warm wet compress to the perineum. Once the presenting part is distending the perineum, NICE recommends offering a warm wet compress. But here's the part I really want you to remember for the exam. There is another intervention mentioned in the guideline, perineal massage with a water-soluble lubricant, but the wording is different. Warm wet compress offer and perineal massage consider if acceptable to the woman. And the exam absolutely loves guideline verbs. So offer, consider, recommend, do not offer, routinely. These words are not interchangeable. So memory line is offer warm compresses and consider perineal massage. And obviously routine episiotomy is not the answer. Okay. So which brings us perfectly to question number 17. A nulliparous woman has an uncomplicated spontaneous vaginal birth and progressing normally. The fetal heart rate is reassuring. Which statement regarding episiotomy is most appropriate? Should be performed. Routine episiotomy reduces third and fourth degree tear. Routine episiotomy is recommended in nulliparous women. Routine episiotomy should not be carried out during spontaneous vaginal birth. Episiotomy should routinely be offered before crowning. Absolutely not. Should we perform an episiotomy because she is nulliparous? Absolutely not. Correct answer is C. Routine episiotomy should not be carried out during spontaneous vaginal birth. Episiotomy is an indication-based intervention, not a routine part of vaginal birth. It may be clinically indicated in situations such as some instrumental birth or when expedited birth is required because of suspected fetal compromise. But nulliparity itself is not an indication. And another important misconception, routine episiotomy does not eliminate the risk of obstetric anal sphincter injury. So in the exam, if they give you an uncomplicated spontaneous birth and try to sell episiotomy as a preventive routine procedure, rejected. No routine episiotomy. Use it when clinically indicated. Now the examiner makes it more tempting. This woman previously had a third degree tear. Naturally, she is worried about the recurrence and asks whether she should have a prophylactic episiotomy in this pregnancy. Now you might think previous sources better to do an episiotomy routinely, but that is exactly the trap. A, episiotomy is mandatory because of the previous third-degree tear. B, elective C-section is mandatory. C, episiotomy should be performed routinely at crowning. D, episiotomy should be based on the current clinical situation rather than performed routinely. E, previous severe perineal trauma contraindicates vaginal birth. The correct answer is D, episiotomy should be based on the current clinical circumstances rather than performed routinely. A previous third or fourth degree tear does not automatically mean routine episiotomy next time. And it also does not automatically mean mandatory cesarean birth. Management needs to be, yes, please, individualized. The previous injury, the current symptom, the previous investigations were relevant. Women's preferences and the circumstances of the current birth all matter. For the specific question about episiotomy, remember, the previous OBS and sphincter injury does not mean automatic episiotomy. There should be a current clinical indication. That distinction is extremely important. Now, now suppose an episiotomy actually is now clinically indicated. During instrumental vaginal birth, an episiotomy is clinically indicated. Which technique is most appropriate? A, midline episiotomy directed towards anus. No. Mediolateral episiotomy starting at the posterior foresheet directed to the right side at 45 to 60 degrees. This is the number you should know. When the perineum is distended, the episiotomy is performed mediolaterally, originating at the posterior vaginal foresheet and directed at approximately 45 to 60 degrees from the vertical axis. Why are we not choosing the midline option? Because the recommended technique here is mediolateral, not a cut directed straight towards the anus. So write this number somewhere in your memory, 45 to 60 degrees. If the examiner asks episiotomy indicated technique, your brain should immediately say mediolateral, posterior foresheet, the right side, and 45 to 60 degrees. It is very high. And question number 20. A nulliparous woman has been pushing for 50 minutes. Progress is now slow but continuing, and fetal assessment remains reassuring. A colleague suggests applying manual fundal pressure during contraction to accelerate the birth. What is the most appropriate management? A, apply fundal pressure with each contraction. B, apply fundal pressure only during maternal pushing. C, apply fundal pressure after obtaining consent. D, do not use fundal pressure to facilitate the birth. E, use fundal pressure only in nulliparous women. The answer is a very clear no. The correct answer is do not use fundal pressure to facilitate birth. Fundal pressure should not be used as a shortcut for slow progress. Slow progress means assist the woman. Look at contraction, the fetal position, the descent, the maternal condition, the fetal well-being. It does not mean someone should physically press on the uterine fundus to force the baby down. There's no established benefit to justify routine fundal pressure, and there is potential for maternal and neonatal harm. So remember this very simple line, slow progress assist, don't press. And that completes this block of second stage questions. Okay. Now question number 21. A healthy 29-year-old woman has an uncomplicated spontaneous vaginal birth at term. During antenatal counseling, she expressed a preference for physiological management of third stage. Immediately after birth, both mother and baby are well. What is the most appropriate management? The thing is, our patient is healthy. She has an uncomplicated spontaneous vaginal birth. Mother and baby are both well. And during antenatal counseling, she clearly expressed a preference for physiological management. What should we do? Respect her choice and proceed with physiological management. Now, this question is testing something bigger than just third stage management. Yes, active management is associated with a lower risk of PPH and blood transfusion, and we should explain this when counseling women. But does that mean active management is mandatory for every woman? No. If an informed woman chooses physiological management and there is no clinical contraindication, her choice should be supported. This is a recurrent NICE principle. Recommend based on evidence. Explain the benefit and risk. Respect the informed maternal choice. But remember the final part, we continue monitoring her. If significant bleeding happens, the placenta becomes retained, or maternal condition deteriorates, the clinical situation has changed. and the management may need to be changed too. So the example is physiological management is a valid informed choice in an appropriate clinical situation. Now, question number 22 asks you to define it. A woman requires physiological management of third state. Which combination best represents physiological management? This is important because students often confuse late cord clamping with physiological management. Delayed cord clamping alone does not define physiological management. The correct answer is B. No routine uterotonic plus cord clamping after pulsation stop plus spontaneous placental delivery. Let's break physiological management into three components. Number one, no routine uterotonic. Number two, the cord is not clamped until pulsation has stopped or until after placental delivery. And number three, the placenta delivers spontaneously or with maternal effort. And here comes your big differentiating point: no controlled cord traction. If you see controlled cord traction in an option, that option is describing an element of, yes, please, active management and not purely physiological management. So memorize this as a package. Physiological, no routine uterotonics, no early cord clamping, and spontaneous placental delivery. Simple. Okay. Question number 23. What a woman chooses active management of the third state following an uncomplicated vaginal birth. Which combination best describes active management? A, routine uterotonic plus cord clamping, cutting plus controlled cord traction. Again, think of this as a three-part package. Flip the previous question. 1, prophylactic uterotonic. 2, cord clamping and cutting. 3, controlled cord traction. And clinically, why do we generally recommend active management? Because compared with physiological management, it is associated with a decreased risk of postpartum hemorrhage and blood transfusion. But there is another important point. It is not enough to memorize these three components. You need to understand their sequence. We don't just give a uterotonic and immediately start pulling on the cord. Controlled cord traction has to be performed appropriately. And that takes us directly to question number 24. A woman has chosen active management. Oxytocin has been administered immediately following birth. The cord has been appropriately clamped. When should controlled cord traction be performed? A, immediately after birth, before the uterotonic. B, immediately after the oxytocin, irrespective of the placental separation. C, only after oxytocin administration and signs of placental separation. D, only after 30 minutes. And E, only when the woman develops an urge to push. This is a very practical exam question. The woman has chosen active management. Oxytocin has been administered and the cord has been appropriately clamped. When should controlled cord traction be performed? The correct answer is C. Only after oxytocin administration and the signs of placental separation. Now notice option B. Immediately after oxytocin, irrespective of placental separation. That sounds active, it sounds efficient, but it is wrong. Giving oxytocin does not mean injection in, immediately pull the cord. No. You wait for uterine contraction and signs that the placenta has separated and then perform controlled cord traction. So the sequence in your head should be uterotonic, uterine contraction, placental separation, then controlled cord traction, deliver and inspect the placenta, and then ensure that the uterus is contracted. And please remember, controlled cord traction means controlled traction with appropriate uterine support. It does not mean simply pulling on the cord. So if the examiner gives you oxytocin has just been given, what next? Don't automatically choose immediate traction. Oxytocin first, then separation, then controlled cord traction. Now we come to a favorite numerical question. A term baby is born vaginally and is vigorous. The mother has chosen active management of the third state. There is no concern about the cord. When should the cord be clamped? A, immediately after birth. B, within 30 seconds. C, not earlier than 1 minute after birth. D, exactly 5 minutes after birth. C, correct answer is not earlier than 1 minute after birth. This is important because some people still associate active management with immediate cord clamping. That is outdated thinking. Active management does not mean clamp the cord immediately. According to NICE, in active management, do not clamp the cord earlier than 1 minute after birth unless there is a specific reason for earlier clamping. And there are two important exceptions we are going to discuss. Now there's another number of 5 minutes. In active management, the cord is generally clamped before 5 minutes. So that control cord traction can be performed. So exam numbers are not before 4 minutes, not before 1 minute, Generally before 5 minutes. But, and this is important, 5 minutes is not an absolute wall, because look at the next question. A healthy term baby is born in good condition. The mother has chosen active management but asked for the cord not to be clamped until 7 minutes after birth. Mother and baby remain well. What is the most appropriate response? A, refuse because the cord must always be clamped by 5 minutes. B, clamp at exactly 5 minutes regardless of maternal preference. Obviously wrong. C, support her request for later cord clamping. D, convert automatically to physiological management. E, explain the delayed clamping beyond 5 minutes is contraindicated. This question is excellent because it tests whether you understand the difference between a guideline recommendation and an absolute prohibition. Mother and baby are healthy. The woman has chosen active management, but she requests that the cord should not be clamped until 7 minutes after birth. What should you do? The correct answer is C, to support her request for later cord clamping. Now, someone may say, but we just learned that in active management, the cord should generally be clamped before 5 minutes. Exactly, generally. If the woman requests cord clamping later than 5 minutes and the clinical situation permits a choice, should be supported. So again, NICE brings us back to the informed decision making. We explain the recommended approach. We explain why cord clamping before 5 minutes facilitate control cord traction. But if the mother and baby remain well and she requests later clamping, we don't simply say no, guidelines say 5 minutes. That is not shared decision making. So remember, before 5 minutes recommended in active management, but not an absolutely mandatory cutoff. And this is why reading the exact language of guideline matters so much in exam. Now, I told you there were exceptions to our 1 minute rule. Here they are. A baby is born following an uncomplicated vaginal birth. The cord is intact, but the neonatal heart is 50 beats per minute and is not increasing despite initial measures. What is the most appropriate approach to cord clamping? A, cord clamping must always be delayed for at least 1 minute. B, early cord clamping may be appropriate. C, cord clamping must be delayed for 5 minutes. D, wait until cord pulsation ceases. E, wait for placental separation before clamping. The baby is born. The cord is intact, but the neonatal heart rate is decreasing. Should we still insist on waiting for 1 minute? No. The correct answer is B. Early cord clamping may be appropriate. NICE tells us not to clamp earlier than 1 minute unless there is concern about the cord integrity or the baby's heart rate is below 60 beats per minute and is not increasing. Our baby has a heart rate of 50 and it is not improving. Therefore, early clamping may be required to facilitate appropriate neonatal resuscitation. This is an excellent example of why you should be suspicious of absolute words in exam question. Always, never, must wait. Ask yourself, is there an exception? So your memory line is that cord clamping not before 1 minute, except cord concern or initial heart rate less than 60 and not increasing. Very high yield. Now we come to another pair of numbers you absolutely need to know. A woman chooses physiological management 1 hour after birth. The placenta remains undelivered. She has no significant bleeding and is hemodynamically stable. What is the most appropriate interpretation? A, this is still within the normal duration of physiological third stage. B, the third stage is prolonged. C, PPH should be diagnosed. G, control contraction should be performed immediately without tonic. And E, no interventions required until 2 hours have elapsed. Okay. A woman has chosen physiological birth, 1 hour passed, placenta not delivered. What does that mean? The correct answer is B. The third stage is prolonged. Now here's the example. The definition depends on which management approach is being used. With active management, the third stage is considered prolonged if it is not completed within 30 minutes. With physiological management, it is considered prolonged if it is not completed within 60 minutes. So active 30, physiological 60. Don't mix these up. And notice that it's 60 minutes in this scenario. We are not diagnosing PPS simply because the placenta has not delivered. PPS is about abnormal bleeding, not merely the elapsed time. Okay. Now, question number 29. A woman undergoing physiological management has not delivered her placenta. 35 minutes after birth, she now develops significant vaginal bleeding. What is the most appropriate management? A, continue physiological management until 60 minutes. B, wait until cord pulsation stops before intervening. C, change to active management and manage the hemorrhage appropriately. D, encourage breastfeeding and reassess after another 30 minutes. C, only 35 minutes have passed. The logical management is ongoing. So technically, we have not reached a 60-minute threshold for prolonged third state. But now the woman develops significant vaginal bleeding. Should we say, don't worry, physiological management allows 60 minutes, let's wait another 25 minutes? Absolutely not. The correct answer is C, change to active management and manage the hemorrhage appropriately. This is one of the most important principles in the entire block. Clinical deterioration beats the clock. The 30-minute and 60-minute threshold applies to a stable and complicated situation. They are not permission to ignore hemorrhage. If significant bleeding is occurring, reassess the situation. The mother initiate appropriate management and resuscitation as required, and escalate or transfer to obstetric-led care where appropriate. The same principle applies if you develop concerns such as retained placenta with complication, maternal collapse, or other deterioration of maternal well-being. So physiological management for 35 minutes as well, you may continue observation. But physiological management plus 35 minutes and now significant bleeding, act now. Now, never let a guideline number override a deteriorating patient. Okay. A woman is awaiting placental delivery following an uncomplicated vaginal birth, which observations should routinely be recorded during the third state. And C, do we need blood pressure every 5 minutes in every healthy woman? Blood pressure every 5 minutes and temperature every 15 minutes. B, pulse and respiratory rate every 5 minutes. C, maternal physical condition, vaginal blood loss. And D, maternal temperature, urine output only. And E, continuous ECG and oxygen saturation. The correct answer is C, maternal general physical condition and vaginal blood loss. During third stage, routinely assess the woman's general physical condition. That includes like her color, her respiration, how she looks, and importantly, how she says she feels, and assess the vaginal blood loss. This is a lovely reminder that good intrapartum care is not just a monitor full of numbers. Look at the woman, listen to the woman, assess the bleeding, and if she develops postpartum hemorrhage, retained placenta, maternal collapse, or another concern about her well-being, then of course the frequency and intensity of observation increase, and to assess the need for resuscitation, escalation of care. But for routine third state observation, remember that condition plus blood loss, that is your exam answer. Okay. Now, question number 31. We have a woman with retained placenta following vaginal birth. She is hemodynamically stable with no major hemorrhage. Vaginal examination suggests that manual removal will be required. Which is the most appropriate management? A, perform manual removal immediately without analgesia. B, perform uterine exploration under Antonox alone. C, ensure adequate analgesia and anesthesia before uterine exploration. D, give IV oxytocin routinely solely to deliver the retained placenta. And E, apply sustained contraction until the placenta separate. The question asks, what is the most appropriate management? The correct answer is C, ensure adequate analgesia or anesthesia before uterine exploration. Now, this is an important patient safety principle. Even though the woman is stable, manual removal of placenta involves inserting the hand into uterine cavity. This is a painful, invasive procedure. So adequate anesthesia must be provided. Do not fall into the trap of thinking she is stable, so we can quickly remove the placenta without anesthesia. No. Hemodynamic stability does not remove the requirement for appropriate anesthesia. And Antonox alone is not considered adequate for uterine exploration or manual removal. Also notice option D, routinely giving IV oxytocin solely to deliver a retained placenta. This is not appropriate answer here. And sustained contraction on the cord is certainly not appropriate because of the risk of complications, including uterine inversion. So remember this exam simple line. In retained placenta requiring manual removal, adequate analgesia or anesthesia is first. Now the scenario changes dramatically. This woman has also retained placenta, but now she develops heavy vaginal bleeding. She is tachycardic and her blood pressure is falling. What is the most appropriate management? I think you should immediately say, without looking at the key, call for help, initiate immediate PPS treatment, and arrange obstetric-led care. And this question is testing a very important principle. Clinical deterioration overrides the clock. Students sometimes memorize third stage timing so rigidly that they forget to look at the patient. You may remember that we have different time threshold for a prolonged third state, but those threshold apply to a stable, uncomplicated woman. If she's bleeding heavily, becoming tachycardic and hypotensive, you do not wait for 30 minutes or 60 minutes. You act immediately. Call for senior help, assess, resuscitate the moment, identify and treat the cause of the hemorrhage, and arrange appropriate obstetric-led management. And please note another classic trap. Ultrasound before treatment, no. In an unstable woman with major bleeding, investigations must never delay resuscitation. So the exam equation is in retained placenta and heavy bleeding plus hemodynamic compromise is PPH. Act now. Don't watch the clock. Watch the patient. Okay. Now this question gives us a classic principle. 10 minutes after vaginal birth, the woman develops heavy vaginal bleeding and the uterus feels poorly contracted. What is likely happening here? This is postpartum hemorrhage. And a poorly contracted uterus immediately points us towards the uterine anatomy. The best combination is A, uterine massage, empty the bladder, give uterotonic and IV fluids. This question is not asking you to perform one intervention and then wait to see what happens. PPH management happens simultaneously. Call for help. Assess airway breathing circulation while treatment begins. Empty the bladder because a distended bladder can interfere with effective uterine contraction. Massage the uterus. Give appropriate uterotonic. Establish IV line and begin fluid resuscitation as required. At the same time, quantify the blood loss. Monitor the maternal condition and identify the underlying cause. If the placenta has not yet delivered, control contraction will also form part of the management in the appropriate setting. The big trap here is option E, ultrasound followed by uterotonic treatment. Never delay immediate PPH treatment while waiting for imaging. So remember, stabilize first, then investigate and treat the cause simultaneously. And for your Viva question, keep the 4 T's in the back of your mind. Tone, trauma, tissue, thrombin. Here, the boggy, poorly contracted uterus strongest rest tone. That is the uterine atony. Okay. Now, this question is a nice number-based question. A woman develops a major PPH. She is receiving active resuscitation. Supplementary oxygen is considered according to NICE, which is the most appropriate approach. A, oxygen should never be administered unless she loses consciousness. B, give 2 liters per minute via nasal cannula routinely. C, consider high flow oxygen starting at 15 liters per minute, targeting saturation 94 to 98%. C, the best answer is C. Consider high flow oxygen starting at 15 liters per minute, targeting an oxygen saturation of 94 to 98%. If supplementary oxygen is required in this context, use a non-rebreathing mask with a reservoir with high flow oxygen initially. The numbers you need to remember from this slide are 15 liters per minute and saturation target 94 to 98%. But there's another conceptual point. Oxygen is an adjunct to resuscitation. It does not replace volume resuscitation, uterotonics or hemorrhage control or treatment of the underlying cause. So never think we have given oxygen, now the patient is being treated. No, you are supporting oxygenation while simultaneously treating the hemorrhage. So example is a PPH resuscitation simultaneous, not sequential. Okay. Now we move from third stage complication to meconium. A low-risk woman laboring in a midwifery-led setting develops meconium-stained liquor after spontaneous rupture of membrane. What is the most appropriate next step? A, immediate emergency cesarean section. B, ignore the finding the fetal heart rate is currently normal. It is not like that. C, perform a full risk assessment and discuss the option of transfer for continuous CTG monitoring. Yes. Other options are commence antibiotic routinely, no. Perform fetal blood cell, no. See, the first misconception I want you to remove is meconium does not automatically mean C-section. The presence of meconium changes the risk assessment and feature surveillance, but the mode of birth depends on the complete clinical picture. Assess the character of meconium. Assess the fetal heart rate pattern. Consider the stage of the labor, the maternal temperature, other risk factors, and the current place of birth. Then determine the appropriate monitoring and whether transfer to obstetric-led care should be discussed. So don't use immediate C-section simply because you see the word meconium. And don't ignore meconium simply because the fetal heart rate currently appears reassuring. The current approach is reassess, then monitor, and then decide. Very high-yield exam principle. A term baby is born through meconium-stained liquor. A baby has normal respiration, heart rate, and tone immediately after birth. What is the most appropriate management? A, routine tracheal suction before stimulation, no. B, routine nasopharyngeal suction, no. C, routine oropharyngeal suction, no. D, provide normal immediate newborn care without routine suctioning, yes. Look carefully at the baby. if normal respiration, normal heartbeat, normal tone, in other words, it's a vigorous baby, what should we do? Provide normal immediate newborn care without routine suction. This is extremely important because older teaching created a strong association between meconium and immediate suctioning. That is not the routine approach for a vigorous newborn. A vigorous baby born through Meconium-stained liquor does not require routine tracheal suction, routine oropharyngeal suction, routine nasopharyngeal suction, or routine intubation simply because meconium is present. Provide normal immediate newborn care. Keep the baby warm, dry appropriately, assist the breathing and tone, facilitate skin-to-skin contact, and support early breastfeeding. The management depends primarily on the condition of the baby, not the color of the liquor. So whenever you see meconium and the baby is okay, think routine newborn care, no routine suction. This is an exam point. Now, a healthy term baby is born vaginally and requires no resuscitation. Mother and baby are clinically well. What is the most appropriate immediate care? A, separate the baby for routine weighing before maternal contact. No, please. Encourage skin-to-skin contact as soon as possible after birth. Bath the baby immediately. Delay maternal contact. Routine admission to natal unit. C, what is the most appropriate immediate care? The answer is B, encourage skin-to-skin contact as soon as possible after birth. This may sound like a very simple question, but these questions are testing whether we unnecessarily medicalize normal birth. A healthy mother and a healthy newborn should not be separated simply for routine procedures. Early skin-to-skin contact supports thermoregulation, bonding, breastfeeding, and helps physiological adaptation after birth. Routine weighing does not need to happen before maternal contact. Routine observations and other non-urgent procedures should not unnecessarily interpret this period. And certainly, we did not routinely admit a healthy term newborn to the neonatal unit merely for observation. Okay? Now, a healthy woman asked when she should first breastfeed her well-term baby following an uncomplicated vaginal birth. Very simple question and very simple answer. Encourage breastfeeding. Option C, encourage breastfeeding as soon as possible when mother and baby are ready. Notice the wording. We are not waiting for an arbitrary 2-hour interval. We are not waiting for weighing. We are not waiting for placental delivery simply because it is a routine sequence on the ward. And we certainly do not routinely give formula to the healthy term newborn to prevent hypoglycemia. Instead, support early initiation of breastfeeding when mother and baby are ready. Early breastfeeding promotes bonding, supports thermoregulation and glucose homeostasis, and helps establish lactation. Again, routine procedures should not be unnecessarily interfere with early maternal newborn contact and feeding. So a simple exam line, well mother, well baby, breastfeed early, breastfeed often. Now, question number 39 asks something that is very easy to underestimate. The third stage has finished. She's comfortable and her baby is well. Can we simply say everything is fine and finished? No. A structured post-birth assessment is still required. C, assess maternal observations, uterine contraction, vaginal blood loss, and completeness of the placental membrane. After birth, assess the woman's overall clinical condition and observation. Check uterine contraction and tone, assess the vaginal blood loss, and examine the placental membrane for completeness. Why? Because an uncomplicated delivery does not guarantee that complications cannot subsequently develop. For example, a woman can initially appear well and then develop uterine tuning or significant bleeding. Similarly, incomplete placental membranes will suggest retained tissue. But routine invasive investigation is not required in otherwise uncomplicated women. So no routine speculum examination for everybody. No routine ultrasound simply to exclude retained product. Remember these four post-birth check: observation, uterus, blood loss, placental membrane. Assess, document, and communicate. Now, question number 40. A nulliparous woman has an uncomplicated vaginal birth following spontaneous labor. She initially requested physiological management of third stage. 20 minutes after birth, the placenta has not delivered. She just suddenly develops heavy vaginal bleeding. The uterus feels boggy. She becomes dizzy. Pulse is 125. BP is 80-50. Now, this question brings several of our previous concepts together. And this is exactly the type of question where candidates can get distracted by one memorized number. Now, if I stop the scenario, and some of you may need to start thinking about the duration allowed for physiological management, but keep reading. She suddenly develops heavy vaginal bleeding. The uterus is boggy. She becomes dizzy. Her pulse is 125 beats per minute. And her blood pressure is 85/50. Now tell me, does the physiological management time limit matter anymore? No. The correct answer is C. Call for help and immediately initiate treatment for postpartum hemorrhage. This woman is actively bleeding and has evidence of hemodynamic compromise. Our previous preference for physiological management does not mean that we continue watching her deteriorate until a predefined time limit is reached. This is the central lesson. Maternal deterioration overrides the routine timelines. Call for help. Assess and resuscitate using an airway breathing circulation approach. Establish IV line and initiate appropriate fluid and hemorrhage management. Empty the bladder. Massage the bogey uterus. Give appropriate uterotonics. Quantify and continuously reassess the blood loss. Identify and treat the cause. Escalate to obstetric-led care immediately. If the placenta remains undelivered, this must also be addressed as a part of the management of the hemorrhage. The examiner is deliberately tempting you with physiological third stage can continue longer. No, the patient is bleeding, tachycardic, hypotensive. That changes everything. So if you remember only one sentence from this question, remember this. The clock applies to the stable patient. Clinical deterioration overrides the clock. And this principle does not only apply to the third stage of labor, it applies throughout the obstetrics. Treat the woman in front of you, not just the number in the guideline. So, finally, and with that, we have finally completed our intrapartum care SBA discussion. We did it. And if you stayed with me till the end, I really hope you're not just memorizing answers anymore. I hope you're starting to understand how the examiner wants you to think. Because that is the whole purpose of these SBA sessions. Not simply knowing the guideline, but knowing how to apply it when the clinical scenario changes. Thank you so much for staying with me, for learning with me, and especially for appreciating the work I put into these lectures. Your comments, your messages, and support genuinely motivate me to keep creating better content for you. But a labor module is not over yet. In the next lecture, we are moving to one of the most important, most tested areas of the intrapartum care, the fetal monitoring in labor. We'll cover it with an evidence-based approach, focusing on the updated NICE guideline, clinical decision-making, CTG interpretation, of course, the points that can actually trap in your exam. So revise what we have covered today, and I'll see you in the next lecture. Until then, keep learning, keep growing, keep shining. Like, share, and share this lecture with your colleagues and subscribe. And Allah Hafiz, and I will see you in the next one.